Welcome to our conference session titled Understanding Aplastic Anemia. Thank you for joining us. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of the corporate sponsors and the generous support of our patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. Please feel free to submit questions at any time during the presentation using the Q&A icon in the engagement panel to your right. Submit a question or comment, type your question in the Q&A text box window, and when you have finished typing, just hit enter. We will do our best to get to everyone's questions today. Submit your entire question all at the same time. Please do not share private health information in your question. Our speaker cannot answer any specific questions related to your personal health care. Today's specialist is Anna Kogut. Dr. Kogut graduated with honors from the Lake Erie College of Osteopathic Medicine. She completed her residency at the University of Pittsburgh Medical Center, Shadyside, and a fellowship at the Allegheny Health and West Penn Medical Education Consortium. Dr. Kogut holds a board certification with the American Board of Internal Medicine Hematology. With that said, it is my pleasure to welcome Dr. Kogut.
Thank you very much. Thank you so much to everyone for attending today. And I'm just going to share my screen. Okay, so today we'll be talking about aplastic anemia, and to make sure that we cover everything from the diagnosis to treatment, and we'll have some time to answer some questions. So aplastic anemia can be both congenital and an acquired disorder. I'm not going to talk too much about congenital, and congenital means you were born with it, because typically those type of patients are diagnosed as children, and this is a little bit out of the scope of my practice. I practice in adult medicine, but I'll mention some disorders that can be picked up in young adults as well. So for the most part, it's an acquired stem cell disorder. And unfortunately, a lot of times we never find out what the cause is. And about 70 to 75% of the time, we call aplastic anemia idiopathic, meaning we did not find the cause and we don't know what caused it to happen. And it is also something that we call diagnosis of exclusion, meaning we have to rule out other diseases in order to come to the conclusion that the diagnosis is aplastic anemia. And it is very important to differentiate it from other causes of bone marrow failure, because the treatment is completely different. So why does aplastic anemia happen? It can happen, there are several different mechanisms how it can happen. It either happens due to the direct damage to our chromosomes, which carries our genetic material or DNA, and that can happen from an insult from a chemical or radiation, or more common, it's an inappropriate immune system activation by some sort of trigger. It could be an infection, it could be a viral infection, it could be a drug, it could be an autoimmune disorder. And something happens where the T cells get activated and they attack our own bone marrow, causing the bone marrow failure, and as a result, low blood counts. How do patients usually present with aplastic anemia? Well, the most common presentation is due to the low blood counts. And there are three cell lines that we are considering: red cells, platelets, and white cells. So if the red cells become low, patients develop something we call anemia. And anemia can present with fatigue. It can be shortness of breath, especially on exertion. You will often hear patients saying, I climbed the stairs and that's when I'm short of breath. Or they can be pale. They can have some chest pain. They can have palpitations, feeling like their heart's fluttering and things like that. Also, commonly, you develop low platelet count thrombocytopenia, which can present as either bleeding or bruising. You can develop small dots on your body called petechiae, or it can be bigger bruises called ecchymosis. And that's how that presents. And the third one is low white count. When your white count is low, you're open up to all kinds of infections. They could be bacterial, they could be viral, they could be fungal. You can have a fever. Or some people will not have a fever and just have infection. What kind
Dr.
of...
Kogut,
Yes.
I apologize. Can we just switch the views for your slides? Swap the screen in the display mode.
Yes.
And present. And then at the top in display settings.
Yeah. Is that better?
Perfect. Thank you. Sorry to interrupt.
No problem. So what kind of labs do we get to diagnose aplastic anemia? Well, usually the labs show pancytopenia, which means all cell lines, all 3 cell lines are low. And we also check something called reticulocyte count, which helps us to determine how the bone marrow is responding to the degree of anemia and thrombocytopenia. And that is usually very low in patients with aplastic anemia. We'll talk a little bit about epidemiology. So aplastic anemia is a rare disorder. It's about 2 per million in United States and other Western countries, and a little bit more common in Asia, 4 to 6 per million. There are 2 incidence peaks of the disease. It either presents in young adults, and that means up to the age of 40, or in elderly after the age of 65. And like I said, some patients will have an inherited disorder, and that's more common in children, but also some of the young adults, like really young adults up to the age of 40, up to 15% of those will have an inherited cause. We've known about aplastic anemia for quite some time. The first case was described actually in a pregnant woman in 1888, but the term aplastic anemia was coined in 1904. And of course, all the treatments have advanced since then, and we'll talk about that. The way we diagnose aplastic anemia is we perform something called a bone marrow biopsy. That procedure, it can be done in the office or in the hospital. What we do is we identify this landmark, and that's at the back. In the back, if you kind of put your hands on your hips, you can feel those bones sticking out in your back. And we numb it up. And then we go in and take a liquid portion of the marrow called an aspirate, and then we also take a piece of the bone. And then we send it to pathology, and pathologists will look at it under the microscope and tell us what they see. And what they see in aplastic anemia is typically an empty bone marrow. So you can see that this is the typical bone marrow, and you can see all kinds of cells here. And there are some empty spots, but then for the most part, there are a lot of cells. And in aplastic anemia, it's the other way around. It's mostly empty. There are no cells. There's a lot of white stuff that you see here, and the bone marrow is empty. So what the pathologists will tell us, first thing they will report is the cellularity. And the normal cellularity in a normal patient is 100 minus your age. So say if you're 60 years old, the normal cellularity for you will be 40%. They shouldn't see on your bone marrow any kind of indication of other processes. So we also look for blasts, which are leukemic cells, immature cells that would indicate there is some other process going on. We look for dysplasia, which would be an evidence for something we call myelodysplastic syndrome, or MDS. And we also look for fibrosis, because fibrosis is the scarring of the bone marrow, which can also indicate a different process that is going on. What they will also look at is the stem cells, which is the CD34, which is a marker for the stem cells. Stem cells are immature cells that have not made up their mind yet what kind of cell they want to be. And normally, we all have over 1% of stem cells in our bone marrow. In patients with aplastic anemia, that number is really low. Either they're absent completely or they're 0.1, 0.2%, which is very low. You will also see, like we saw in the picture, the marrow is empty, so there are no white cells, red cells, or platelets, and their precursors there. The lymphocyte number is typically in aplastic anemia normal, and the chromosome analysis, which is genetic material that we will send from the bone marrow, is typically normal. Although you can have some abnormalities that are in aplastic anemia are transient and will resolve with time. Based on that information that we received from a pathologist, we will then try to find out how severe aplastic anemia is. And that is important because based on the severity, that changes the treatment as well. So there are a couple of things that we watch for when we're trying to determine the severity. One is the cellularity. And like I said, the pathologist will report that on your bone marrow biopsy. For non-severe aplastic anemia, should have less than 30% cellularity, and 2 cytopenias, and cytopenias mean blood counts are low. So it could be either red cells and platelets, red cells and white cells. So at least 2 cytopenias or more, but not meeting criteria for 2 other severity levels. The severe aplastic anemia, you should have 2 of the following. The neutrophil count should be less than 500, absolute neutrophil count, the platelets less than 20, and reticulocyte count that I mentioned before should be less than 60. As long as you have 2 or more of those, and the cellularity is less than 25%, you meet the criteria for severe aplastic anemia. And then very severe aplastic anemia is similar to this, except that this absolute neutrophil count will be less than 200 and not 500. So what are the causes of aplastic anemia? I mentioned before that for the most part, we will never know. So 75% are idiopathic and we can't really link it to anything. The other things that have been described in the literature and that we know are associated with aplastic anemia are some chemicals. So there's benzene has a known association, some insecticides and pesticides known, but a lot of times it's very difficult to prove that that's the case. Radiation is a known cause of aplastic anemia. Some medications, some antibiotics, so chloramphenicol is an older antibiotic that is not used that often anymore. But some other antibiotics, penicillin, can be associated. The NSAIDs, such as Advil and ibuprofen, has a known association. Quinines, a lot of times are not used anymore either, but they can be associated. Infections are pretty common triggers for aplastic anemia. We always check patients who are being worked up for that for HIV and hepatitis. COVID is the more recent one that has been associated. Rarely you can see some other viruses such as cytomegalovirus or Epstein-Barr virus, which is the mononucleosis virus, to be associated as well. So we will always check for that, but it's not very common. Pregnancy is a known trigger, so we always make sure that we check that in age-appropriate females. Eating disorders, especially anorexia nervosa, is something that can cause aplastic anemia. And finally, PNH. So PNH is paroxysmal nocturnal hemoglobinuria, which is something that, and I'll talk about it a little bit later, something that can be seen together with aplastic anemia. It's something that needs to be differentiated from aplastic anemia, and we always check for that as well. So this is the typical diagnostic workup. So you can see we do a lot of different tests to make sure, like I said, the aplastic anemia is diagnosis of exclusion. So we need to make sure that we run all this tests to make sure that we have the correct diagnosis. So we always check liver function test. Hepatitis is something that can trigger aplastic anemia. And it typically is not one of the hepatitis that, can be typed. So it's not hepatitis A, B, or C. It will be a presentation of hepatitis, but it doesn't come up on the labs. We always do, like I said, EBV, CMV, HIV testing to make sure. We test for autoimmune diseases. Autoimmune diseases can be a trigger for aplastic anemia. So we do something called ANA, which can be associated with lupus. And we do rheumatoid factor, which is associated with rheumatoid arthritis. We always check for PNH. The PNH, depending on the clone, you can always have a little bit, a small clone of PNH with aplastic anemia that has some prognostic significance. It has some significance on how you're going to respond to immunosuppression, which we will talk about it a little bit later. We always do a pregnancy test. We check for nutritional deficiencies. We always check for B12, folate, and copper levels, because those can cause a similar picture to aplastic anemia as well. This Fanconi anemia testing and telomere length testing, that is looking for congenital causes of aplastic anemia. And like I mentioned, typically it's only in really young adults, because this gets picked up in children most of the time. But sometimes if it was a mild course, young adults in their 20s can have this as well. So this needs to be ruled out. So I'll talk a little bit about the genetic bone marrow failure syndromes. They're very rare. They usually present in children. These children a lot of times have growth failure. They have short stature. A lot of times it's associated with physical abnormalities, especially the skeletal ones, especially fingers, thumbs, and things like that. It is important to pick that up, because it first of all affects how we treat patients. And second, it is associated with increased risk of leukemia and other cancers. Some of the head and neck, some of those diseases can have association with the head and neck cancers, skin cancers, and some other solid cancers as well. So this is an important thing to pick up if that's the case. There are only two diseases that I will mention, because that's the ones that we see a little bit more common in young adults. One is Fanconi anemia. Those patients present with short stature. They usually have skeletal abnormalities. You can see like a very short thumb, or it may be some other finger abnormalities. They usually have something called café au lait spots. You can see those, and they can be either hyper or hypopigmented, meaning they're too light or too dark. And those are the café au lait spots here. And the bone marrow will look kind of like we talked about, empty, and have some features of aplastic anemia. And the other disorder is dyskeratosis congenita, also very rare. And it looks a little bit different. So usually it presents with this lacy, we call it reticular skin pigmentation. You have usually a nail abnormality instead of thumb abnormalities. We call it nail dystrophy. The nail can look disfigured, yellow, or just abnormal. And something we call oral leukoplakia, which is this white patches in the mouth. So that's how dyskeratosis congenita look like. There's something called Amberger syndrome, which presents with this particular mutation, GATA2 mutation, which also can look like aplastic anemia or MDS. And usually you develop this peripheral lymphedema, which is a very swollen legs where the lymphatic system is not working appropriately. It is also important to differentiate aplastic anemia versus hypoplastic MDS or myelodysplastic syndrome. This differentiation in our day-to-day practice sometimes is very, very difficult, because they present exactly the same. Even the pathologists a lot of times cannot say for sure. What helps us is usually the cytogenetic studies, such as chromosome abnormalities. Typically, those cytogenetic abnormalities are more common, especially chromosome 5 and 7. They will be more common in hypoplastic MDS rather than in aplastic anemia. You also will see a lot of dysplasia or abnormality in the cells, in actual multiple cell lines, red cells, platelets, and white cells in the bone marrow, versus you can see a little bit of dysplasia in aplastic anemia, but typically it will be in precursor cells, not in all the cell lines. So it's a difficult differentiation. Again, it's very important to differentiate it, because the treatment and prognosis is completely different. So I'm gonna shift gears and talk about the treatment. This is just the overview of the treatment. The treatment can include supportive care, which is usually transfusions, antibiotics, growth factors, depending on the presentation and severity. Immunosuppression is a big part of the treatment of aplastic anemia, and we'll talk about that. We use something called ATG, or anti-thymocyte globulin, cyclosporin, and steroids. There is a newer drug called Otrombopac that we use now a lot for the treatment of aplastic anemia. And finally, the bone marrow transplant is also a big part of the treatment. So this is a very good overview from an article, and it's a busy slide, but I'll walk you through that. So I'm not going to talk about the children, but in adults, the first thing we determine is, one is the age of the patient, and if the patient is young, and this number is subjective. Some studies you will see will say 40 years old is young, some will say 50 years old is young, but generally we use 40 as a cutoff. And if they have a matched sibling, so a sister or brother, the preferred treatment is to go straight to the bone marrow transplant. If that's not the case, if the patient is older or they do not have the matched sibling, then the preferred treatment is immunosuppression. And more recently, we also started adding a drug called Otrombopac, which we have been using for quite some time in other diseases such as ITP, which is the low platelets. But now we add it to the immunosuppressive regimen. And then we do that, and then it takes quite some time to see if this treatment works. If the treatment works, we just observe patients. If the treatment doesn't work, we have to then either go again towards the transplant, if it's a possibility. If the patient is not eligible for a transplant, then we try a different line of immunosuppression. Or there are some other medications that we can talk about that we can use as well. One thing that we have to be aware of is that the patients with aplastic anemia rarely, but can evolve into other diseases as well, such as MDS or AML. So we have to watch very carefully for that as well. So we'll start by talking about supportive care. So while we are finalizing the diagnosis or finalizing the treatment, we have to make sure that we start supporting patients with whatever we can. A lot of times that means transfusions because the blood counts are very low. We try to keep the platelet count at least above 10, sometimes 20 if there is a lot of bleeding or bruising. And hemoglobin above 7, or depending on how patient feels, sometimes it's necessary to keep it above 8. We try to limit transfusions, especially in patients who potentially can be eligible for transplant. And that is because with every transfusion, there is a chance that you will develop antibodies, which can eliminate some of the donors for you, or can cause some other difficulties to find in a transfusion. Sometimes when you develop antibodies, it becomes very difficult to find the correct blood to transfuse. You should always, in aplastic anemia, avoid transfusions directly from siblings or a family donor. Again, that has to do with the fact that they may be your future donors for the bone marrow transplant, and you should not be getting transfusions from them. That can eliminate them later as a donor potentially. Patients who have low white count, we always start them on antibiotics. We do antifungal prophylaxis. Voriconazole or posaconazole is something that we use. It has good coverage from Aspergillus and mold, so we try to do that. We also do antibacterial and antiviral prophylaxis. There have been multiple studies looking, is there a benefit of GCSF, which is a growth factor that stimulates white cell production? And unfortunately, in aplastic anemia, there is no benefit, so we usually don't use that. Iron overload is something that we also have to be very careful about. Iron overload happens not immediately, but happens once you start getting a lot of different transfusions, especially the red cell. So with every red cell transfusion, you get a load of iron that then deposits in certain organs such as liver and heart. So patients who have a long life expectancy, who continue to require transfusions, may benefit from something called iron chelation therapy, which is trying to bring the iron levels down. Defereserox is the medication that we use in that case because it does not cause a lot of cytopenias and wouldn't make the blood counts worse than they are. Once the treatment works and anemia resolves, we can also use phlebotomy, which is just getting the blood off you. And patients who are already on L-Trombopag, which we'll talk about, one of the medications we use for the treatment of aplastic anemia, it actually has some iron chelating properties as well. So you're already getting iron off if you're on that medication. So the next thing we talk about is immunosuppression. So who benefits from immunosuppression? Well, those are the patients who are a little bit older, over 40 years of age, and may not be eligible immediately for the bone marrow transplant, or younger patients who do not have a matched sibling. The standard of care and the cornerstone of immunosuppression is something we call ATG, which is an anti-thymocyte globulin. There are two variants of that. There is a horse and a rabbit one, and I'll show you how we actually get that from them. We use this medication a lot. It has a good response rate. And I'll show you a study that showed that horse ATG is better than rabbit, although we use rabbit as well in sort of relapse setting. So how do we get ATG? Well, we get it from either a horse or a rabbit, and that's why they get the name horse ATG and rabbit ATG. And what happens is we take cells from the human spleen, thymus, lymph nodes, and then they get injected into the animal, and then the globulin gets extracted, and that's how we make ATG, and then we use it for the treatment of aplastic anemia. Same thing with the rabbit. So the cells get injected into the animal, we purify the protein and extract it, and this is the finished product. Because ATG can cause some side effects, we typically give this treatment as an inpatient, just so we can monitor for the side effects and treat as they come. We give this medication with the steroids to prevent something called serum sickness. Serum sickness can be very stressful for the patients. It's almost like a very bad flu reaction. It can be a rash, it can be fever, it can be chills and rigors, shaking of the body. So that can be pretty significant. So we do give steroids to try to prevent that. ATG has been associated with increased mortality in older patients over 60 years of age. So not everybody is eligible for this treatment, and we have to consider it case by case basis. This IV infusion, we give it for 4 days, and it lasts about 12 to 18 hours. So I already mentioned some of the side effects of ATG, early reactions, including fevers, rash, rigors, which is the shaking that you develop. It can cause some fluctuation in the blood pressure and cause low blood pressure. It can make you retain fluid, which can make you short of breath or have lower extremity swelling. Anaphylaxis can occur, it's very rare, but that can happen. The serum sickness typically is not immediate, but happens 7 to 14 days after the infusion. And typically you have very severe joint aches and pains, muscle aches, rash, or fever. And we treat it either with supportive care or the steroids. And also it can bring the platelets down. When you develop those side effects, the platelet can get consumed by the body and make it even worse than already low platelets, so may require a lot of transfusion. So because of all of that, these patients get treatment as inpatient. So this is a very important point. There was a very big study, very important study that looked at comparison of horse versus rabbit, and it was a very good trial. Usually in medicine, we love prospective trials because that it means we're looking forward, not backwards. So retrospective trials, it means we look at something that already happened. Prospective trials allows us to randomize, and meaning we give treatment to some people and we give placebo to some people, and take a look at that. So this was a randomized, very good trial, randomized prospective trial. It looked at 120 patients, and the endpoint was response at 6 months. And when they compared horse versus rabbit, they saw that horse ATG had a better response. It was 68 versus 37%. Also, the overall survival was much higher, 96 versus 76%. So it was largely in favor of horse ATG. So that would be a preferred treatment to start with. There was 4 deaths in the horse and 14 deaths in the rabbit group. So as a first-line treatment, we would never use rabbit ATG, but rabbit can still be used for patients who did not respond or lost their response. We also combine ATG with another medication that tones down the immune response called cyclosporin. It's a standard of care treatment, and usually you start seeing response pretty quickly. 66% of responses are seen promptly after therapy, but those responses can be very short-lived and not lasting. So only 60% of the patients who look like they responded right away will be in true remission. Remaining patients will either relapse or they will be dependent on cyclosporin administration. And I will talk about it a little bit later, but a lot of times we see a very good response, but once we start tapering or discontinuing cyclosporin, the disease comes back right away. There have been multiple attempts made to increase response rate by adding, intensifying immunosuppression or adding different medications to this regimen, and they all have failed, unfortunately. So in terms of immunosuppression, only ATG and cyclosporin have been proven time after time as effective. Secondary diseases with ATG cyclosporin can still develop. So about 10 to 15% of patients will go on and develop MDS or PNH at 5-year mark. And MDS can then convert, either of those diseases can convert to acute leukemia. So we have to be careful with that as well. There are certain factors that predict for the response to ATG. One of them is young age. Definitely younger patients have a better chance of responding to ATG. Patients who have less severe disease tend to respond better. Some studies have shown that reticulocyte count and lymphocyte count in blood, if it's over 25 and over 1,000 respectively, can predict for a better response to ATG. Certain abnormalities that we see in chromosomes, such as trisomy 8, which is pretty common in aplastic anemia, or deletion 13q, have been shown to predict for the response to ATG. And also, I mentioned this before, the presence of PNH clone. So this does not mean that you have actual PNH disease, but a lot of patients with aplastic anemia have very small clones of PNH that we always check for. And sometimes that can predict for the response to ATG. And that is also something that we can monitor with treatment. So you start the treatment and you monitor the PNH clone, and you can see if it's getting bigger or it's getting smaller. The next medication that we will discuss is eltrombopag, and that is a medication that I already mentioned we've used for quite some time for the treatment of different disorder called ITP, which is chronic idiopathic thrombocytopenic purpura. And it's something that stimulates the TPO. So it's an oral medication. You take it by mouth, and it typically works for the platelets, but what we have seen is that it works very well for aplastic anemia as well. Initially, it was tested as a single agent, and now we use it in combination with immunosuppression. So this was the big study that they did in 2017. They looked at the addition of eltrombopag to the standard treatment, which is ATG and cyclosporin. And they took 3 different groups. So cohorts mean the different groups got different treatment. All cohorts got ATG, which is a standard of care, days 1 to 4. And all cohorts got cyclosporin for 6 months, which is also a standard of care. What they varied is how much and how long of eltrombopag was given. The first group started 2 weeks in the treatment and got day 14 to 6 months. The second group was cut off at 3 months. So they started at day 14, but only went for 3 months. And the third group was the one that had the longest exposure to eltrombopag. So they started on day 1 of treatment and went on for 6 months. And it was a 5-year follow-up. And what they looked at is, was there any response at 3 months mark? And was there any response at 6 months mark? And this is looking at the characteristics of the patients at baseline. And one thing I will point out that you can see the median age here, most of those patients were pretty young. So the median age was 39, 28, 29. and the median age for all patients was 32, although the range was pretty big. So it included patients anywhere from 3 years of age to 82 years of age. Otherwise, all the groups were pretty well matched. So the important findings from the study was that the response rate was very good. So this is a historical response, meaning that this is the response we usually saw before the addition of Otrombopag with just ATG and cyclosporin. And it was 66% historically, but response rate at that study was 87%. So that definitely helped. And that the highest response was in that third group that had the longest exposure to Otrombopag. So those were the patients who started on day 1 and went for 6 months. So they had 94% overall response and 58% complete response, which is very good numbers. And the great majority of the responses was already evident in 3 months. And the average time to transfusion independence, meaning the time when you stop needing transfusions, was 1 month, which is a very good result as well. And the survival rate was over 95% when they looked at the data at 2 years cutoff. One thing that I will mention that was also very surprising to the researchers and a very good sign is that not only did Otrombopag improve the platelet count, which we already knew it can do from the studies we did previously with ITP, but it also improved the actual cellularity of the marrow. So you can see this was a certain patient. They looked at the baseline. This is the baseline cellularity. And at 3 months, you can see it's much improved. So all the cells, if you remember, we looked at the first picture of the empty marrow, which is very similar to this. And all the cells are back at 3 months, and at 6 months, it looks like it's a completely normal marrow with normal cellularity. So it's much better than it was. What were the side effects of Otrombopag? Well, 2 patients had to drop out of the study early because they developed severe rash, which is not something we see commonly with this drug. The liver test abnormalities, it is something that we see commonly, but typically it does not limit administration. Sometimes we have to adjust the dose, but those abnormalities are transient and go away. And when they did the quality of life surveys, it showed that most patients on Otrombopag had improvement in the quality of life that they described. There was an interesting study that was reported in Blood magazine last year that looked at the long-term follow-up of this addition of Otrombopag to immunosuppression. And they actually doubled the sample size and we're looking at 4 years because that cutoff initially that we looked at was 2 years, and now we looked at 4 years. What they found was that the relapse rate was similar to what we saw historically. So it didn't change how many patients relapsed or developed other diseases such as MDS, AML. But what they saw that the median times to relapse and clonal evolution, meaning progression to MDS, was sooner. So it didn't change the fact that if you were going to relapse, you were still going to relapse or develop MDS, but it just happened sooner on Otrombopag rather than later. What that changes for us is not much. We still use Otrombopag, it works great. But if somebody develops clonal evolution, meaning when we do the marrows and we see the chromosomal abnormalities, sometimes we will not use Otrombopag because we know that it will cause the clonal evolution to come sooner. Another thing that that happens is that not everyone is eligible for administration of ATG. Like I mentioned before, patients who are older, over 60 or 65 years of age, they may not be eligible for ATG because we know that ATG is associated with higher mortality in that group of patients. So there's a lot of interest to see if Otrombopag and cyclosporin can be used together without the addition of ATG and what that does for the patients. So there was a trial that was presented last year at the European conference called SOAR trial that looked at just that. It looked at what happens when we combine Otrombopag and cyclosporin without the ATG. And it was a phase 2 trial. They looked at 54 treatment naive adults, so patients who have not had any treatment prior to this, who had severe aplastic anemia, and they were given Otrombopag and cyclosporin for 6 months. And then patients who responded went on and continued cyclosporin for a longer period of time. and they were followed for 18 months for cyclosporin tapering, or until 24 months, or until they relapsed, whichever was sooner. This is the response rate in patients from that trial. And you can see that one important thing that they saw is that younger patients did better than older patients, which was pretty much the same in all the other trials. You will also see that the complete remission, which is the darker area here, the complete remission is much lower than the partial remission. So this combination does not cause complete remission in a lot of patients, but it causes partial remission and allows for a lot of patients to become transfusion independent, which is very important. The adverse events were not that different from any other trials. The adverse events were reported in 83% of the patients, but really the serious treatment events were only in 9% of the patients. The most common were liver function abnormalities, which is, like I said, is very common in L-thrombopec patients and typically does not require any kind of interruption in treatment. Nausea and diarrhea were seen as well. So what they concluded is that L-thrombopec and cyclosporin can be beneficial as a first-line treatment in patients who are not able to get ATG, and it's a pretty good treatment. 72% of patients developed transfusion independence by 6 months, which is a very good result. And even non-responders, patients who did not respond, were able to become transfusion dependent in 50% of the cases, which is very good as well. And 46% of patients had confirmed complete or partial remission by 6 months. So this is very encouraging results of the trial. I mentioned it a little bit before, but I want to make sure that we go over that. The cyclosporin maintenance and taper. In multiple studies, it has been shown that early discontinuation of cyclosporin leads to high rate of relapse. So it's very important not to discontinue cyclosporin early and make sure that you get the significant maintenance, because maintenance delays the response, the relapse of the disease. So we try to make sure that we always monitor the levels of cyclosporin. We try to make sure that they are between 200 and 300, and that has to be fully therapeutic for at least a year. Then at a year mark, we can start considering tapering down cyclosporin, but it has to be very slow. So what we do is we don't decrease the cyclosporin more than 10% at a time, and we do it over the course of another year. So you should be on cyclosporin for at least 2 years. 1 year complete full dose, and then 1 year slow taper. What are the general problems with the immunosuppression? Well, one of the problems is the delayed blood count recovery. Sometimes it takes a long time, up to 2 to 6 months to recover the counts. And meanwhile, you're open up to infections and bleeding and things like that. So it's not frequently an immediate response. Relapse is high. 25 to 40% patients will relapse at 5 years. There are patients who are primary refractory to immunosuppression, meaning they never had any response to the primary treatment, which is 10 to 20%. I already mentioned several times the clonal evolution, which is very important. 25% of patients will have the small PNH clone at the diagnosis, but that can develop to a full-blown disease of PNH, which can have something we call hemolysis. It can increase the risk of blood clots and cause other issues. As well as 20 to 25% at 10-year mark will develop MDS or AML. Which will require a whole another level of treatment. And immunosuppression is never considered to be a curative approach. So we do this and patients can develop remission, but it's not considered to be curative. So you will need to be watched very carefully for a very long time after that. A little bit about clonal evolution. This is something we watch very carefully because it happens 15% of patients will develop evolution to MDS and AML and 10% to PNH. We always check the PNH clone at the time of diagnosis and monitor that. We always check cytogenetic abnormalities on the bone marrow at the time of diagnosis and monitor that as well. So relapse or refractory setting, what can we do for these patients? 35% of patients who initially respond will relapse, and that usually happens, like I mentioned, after or during the cyclosporin taper. So once you start coming down on cyclosporin or shortly after it stops, that's when the chance of relapse is the highest. Another 35% will be refractory to initial treatment. So what we can do is we can either restart, if it happened during the taper or shortly after the taper is complete of cyclosporin, we can reinstate the full dose, and sometimes that helps. Or you can have a second dose, a second round of ATG. So if you got horse ATG initially, you would get rabbit ATG now. And we've mentioned before that although rabbit is not as good as horse for initial treatment, it still works, and it can salvage you as a if you relapse or refractory. So I do use it in my clinical practice, and I have patients who are in remission for several years using that approach. And then, of course, transplant is reserved for patients who were not young initially with a matched sibling, who did not have a transplant up front. Transplant can be used in relapse setting. So what is the role of transplant in aplastic anemia? Initially donors were limited to matched related donors. So only if you had matched sibling, you would get a transplant. Now that's expanded to matched unrelated donor. And for the most part, you can always find a matched unrelated donor. It is rare that you can't. We can also now utilize something we call haploidentical donors, which is a 50% match, and that can be your children, it can be your parent, it can be nieces or nephews. This type of transplant used to be not preferable because it had higher rates of graft versus host disease and other complications. But now that we use something called post-transplant cyclophosphamide, which is a medication you get after the transplant to counteract that, it actually works just as well as matched unrelated donors. So that's a very reasonable option now. And of course, we mentioned that children and young adults who have a matched sibling should undergo transplant right away as a first-line therapy without immunosuppression. What are the complications of transplant? I'm not going to go too much into it. I guess that's for another time. But the main things in aplastic anemia patients that we worry about the transplant is one, failure to engraft, because patients with aplastic anemia do have a slightly higher chance of graft failure. I've also mentioned that because of the transfusions, you can develop the antibodies, which can cause that to happen more commonly. And another thing is graft versus host disease. So we try to utilize conditioning regimen. Conditioning is the chemo regimen that we give before the transplant. We try to utilize the ones that will give less chance of graft versus host disease, but that can still happen. And the mortality with the transplant is at least 20% from the transplant-related complications, and can be higher sometimes, depending on the case-by-case basis. I didn't have this slide in the last time I talked about because COVID didn't exist then, but now we have to consider COVID as a potential cause for aplastic anemia. Of course, because it's brand new, we don't have a lot of information about this, and this mostly is based on case reports. So we don't have any kind of trial data or anything to suggest that, and the consequences of infection in patients with aplastic anemia are not clear as well. The patients who are receiving immunosuppression are considered to be at higher risk of infection. We have seen cases of COVID where COVID was an initiating event in patients with aplastic anemia. There are also case reports of patients where COVID caused lower blood counts in patients with ongoing disease or even those who are in remission. The question always comes up, should patients with aplastic anemia get COVID vaccination? And our American Society of Hematology did put out a statement stating, and again, there's not a lot of data to prove or disprove this, but the current known risk, when in medicine, we always have to consider risk versus benefit. And so the current, what we know is that patients with aplastic anemia should get vaccinated because the benefit overweighs the risk at this time. especially in patients who have other risk factors, such as older age, it could be obesity or other medical problems. It is very important that they get vaccinated. Patients who have received ATG and cyclosporin, they may not have response within 6 months of treatment, but that is something we can watch. We can, there is a test now where we can measure the titer of vaccination, so we can watch that, even though that's not a perfect measure of immunity, but this is something that we can monitor. And patient who had a transplant, they have to follow the transplant guidelines and vaccination, which is currently we vaccinate patients who got transplanted 3 months mark. I will mention aplastic anemia in pregnancy. It's pregnancy, as we talked about, is one of the triggers potentially for aplastic anemia. Supportive care is the mainstay of treatment. If it's possible to just watch pregnant women, we try to do that until delivery and then address whatever issues they still have. We try to keep their platelet counts above 20 rather than 10, of course, to prevent bleeding. If you have to treat pregnant women, cyclosporin is safe. ATG is not, but cyclosporin is safe in pregnancy and can be used. And pregnancy and good obstetrical outcome are definitely possible for women who were previously treated for aplastic anemia. It does not affect fertility. I will mention PNH. All patients should be screened for PNH. As I mentioned, it can be a predictor for how you're going to respond to immunosuppression. It can be also used as a potential way to monitor the response. If it's positive, we test about every 3 months for the first 2 years, and then we reduce frequency to every 6 months or even every once a year. The small clones are detected in up to 50% of the patients. It does not change the management. It's just something we do for the prognostic purpose. If it's a very large clone, that can cause hemolysis, which is the breakdown of red cells, and as well as increased risk of blood clots. So that needs to be watched for very carefully. Treatment in the elderly is very difficult because a lot of treatments that we've mentioned, they are not candidates for, unfortunately, but older age is definitely not a reason to withhold treatment. There are certainly things that we can try. Immunosuppression is the treatment of choice. If they cannot tolerate ATG, we can always consider cyclosporin alone. I've mentioned combination of cyclosporin and L-Trombopac or Promacta. That is a very good option. There's something called Alemtuzumab or Campath, which has a lot of toxicity associated with it, but we can also use if we have to. And there are some other treatments as well. I will also mention romiplastim. Romiplastim is another medication that we frequently use in patients with ITP, which improves the platelet counts. It's also called Nplate is another name for this, and it's an injectable. What we have seen in some studies that it has pretty good response as well and can be used in patients who are not eligible for immunosuppression. There was, in a study, there was 84% hematological response seen at 27 weeks. And even a 39% responded in all 3 cell lines, not just the platelets. Even though this is a platelet medication, you can see response in red cells and white cells as well. The side effects were very mild. Mostly it's headaches and muscle spasms. Nobody had to discontinue treatment because of that. 3 patients had liver toxicity, which we watch for and sometimes have to adjust the dose of the medication. So what they concluded is an effective medicine. It's well tolerated. Important thing in that study that they looked at romiplastim, none of the patients developed MDS or AML, so there was no incidence of clonal evolution with that. The median duration of response was 251 days, which is a pretty long time for somebody who is refractory or has not responded to other treatments. So that's a very good response and is a good option for patients. And I will finish by saying that certainly prognosis of aplastic anemia has changed with treatment. Currently, if left untreated, the mortality is very high, over 70%. But fortunately, with the treatments that we do have available, the current 5 or 10 year survival rate is as high as 80 to 90%. which if you compared it in 1960s, it was 10 to 20%. So we're definitely making a lot of progress. There's a lot of ongoing studies, which we really appreciate as clinicians. We're hopeful that one day this will be cured. Thank you very much, and I will take questions shortly after this. And this is my contact information, my work email, and the number for my clinic. So if anybody needs to contact me about anything, it's available to you. Thank you.
Thank you so much, Dr. Kogut, for the very informative presentation. We do have questions. Our first question is, does tacrolimus 8 to 10 milligrams daily affect one's short-term memory?
That's not a known side effect of tacrolimus, the short-term memory loss. We do use tacrolimus a lot in patients who, for some reason, because of their kidney function or some other problem, cannot use cyclosporin. We do use tacrolimus instead. We also use a lot of tacrolimus in post-transplant patients to prevent graft versus host disease. I have not seen any short-term memory loss in any of my patients. So it's not a known side effect.
Thank you. Why is horse ATG better than rabbit?
It just has to do with the mechanism. We didn't know about it either until that study came out. It's just the way the immune system, you saw, I showed a picture of how ATG is made. It's the immune system of the animal when you get injected with the cells. So that has to do with the mechanism of action, nothing else. It's for some reason the horse is better than the rabbit. And that's why they compared them and they saw that there is a big difference. But it has nothing to do with the patients themselves. It has to do with the animal. It's just they produce a better match with the human, and that's the way it is.
Thank you. Is eltrombopag started on the same day as ATG?
Yes, so I showed that in the initial study, they had several groups of patients and they tried to start it on 14 days and they started it on day 1. And clearly patients who started on day 1 did better than patients who started on day 14. So ideally, you should start it on day 1. But I can tell you in real life, in real practice, that doesn't happen sometimes because some hospitals do not carry eltrombopag. And so you have to obtain it through your insurance and that takes time. And so a lot of times you don't start eltrombopag on day 1 and that's okay. But ideally, if you have it available and if your blood counts and your clinical situation allows to wait, ideally you should start it on day 1 because that's what the study showed was the best regimen.
Thank you. Do you recommend the COVID vaccine weeks before a patient starts ATG? What is the timing of a newly diagnosed patient or a patient getting ready to start treatment? Is there a timeline that's recommended?
Not really. So, I mean, what we know is definitely if you get an ATG, your response will be lower to vaccine. But most of the people, if you are qualifying for ATG, typically you do not have time to wait. Unfortunately, you have to treat, you have to do each case will be different. My guess is there will not be a scenario which you are recommended to get ATG, but you have time to get vaccinated because, fully vaccinated people, it requires 1 dose, then 2nd dose, and then 2 weeks after you consider to be fully vaccinated. That is, for the most part, will not be possible. So you do what needs to be done. If your clinical condition allows to wait, it's of course better to get the vaccinated before you start ATG. But if it doesn't, I certainly wouldn't delay treatment to do that. You can always get vaccinated after and just monitor your response. But certainly the first 6 months, you may not get a good response after ATG.
Thank you. Our next question is, do you know if there are any prospective studies following the immune response of COVID vaccination in patients with aplastic anemia?
I don't think there are any prospective trials in that at all. Unfortunately, this is all looking back, and like I said, the ASH, we go by ASH guidelines, American Society of Hematology. They put out a statement saying patients are recommended to get vaccinated. This is what we go by. I don't think there's any prospective data on vaccination in aplastic anemia patients that I'm aware of.
Thank you. Our next question is, do you have a preference between the use of a trauma pad or end plate?
Yeah, so a trauma pack is preferred, certainly. The response is better in terms of a trauma pack. One thing that I will mention, if you have clonal abnormalities to begin with, so if your marrow showed some chromosomal abnormalities, sometimes that will push me to use rompoplastin versus a trauma pack, because we worry about, I had a slide on that patients on Eltrombopag, they can develop clonal evolution sooner. So something like that may make me pick one over the other, but I would pick Eltrombopag. Definitely has better data. So this is what I use up front. And romiplastin is good in relapse setting, or if you cannot use Eltrombopag, but my first line of choice will be in Eltrombopag.
Thank you. How long would you anticipate a patient be infuse dependent to maintain greater than 10 platelets and or greater than a 7 hemoglobin after ATG?
It takes quite some time. It takes at least several months typically to see transfusion independence. Unfortunately, I would say on average 2 to 4 months.
Thank you. Is it possible for ATG to be given in a community hospital versus an academic center?
It all depends on the facility and what their capability is. I do see, we are academic center here, and so I do see a lot of transfers from community hospitals here. So I would say it's very variable and depends on the facility, but my guess is most of the time it will be transferred to academic center.
Thank you. What is meant by a partial response and a complete response?
Well, complete response is when your blood counts have completely normalized. Partial response, it may be that your blood counts have normalized slightly and you may be transfusion independent, but you're just not at the normal range yet.
Thank you. Is ATG or cyclosporine considered chemotherapy?
No. Both of those medications are immunosuppressive drugs. They're not chemotherapy drugs. They're purely immunosuppressive drugs, and in fact, we use them for other conditions that have nothing to do with aplastic anemia. A lot of autoimmune diseases utilize cyclosporine. We use them for other hematological conditions. We use ATG in transplant patients to prevent graft versus host disease. So it's not a chemo drug at all. It's immunosuppressive medication.
Thank you. This question is from a patient who was given high doses of cyclosporine for many years after their diagnosis of aplastic anemia in 1984. They are experiencing bone health issues. Do we know what the long-term side effects of cyclosporine use is? And could this be causing my bone health issues?
Difficult question, because I don't know. This is very specific to that particular patient. So I don't know what is meant by bone health. Is it osteoporosis? Certainly cyclosporine is a drug that has some side effects, and the long-term use, definitely you will have some issues. I don't know the other information. What is the age of the patient? What is their smoking history? So it's difficult to say if we're talking about osteoporosis, it's difficult to say what exactly is causing that issue. But I can tell you that certainly there is a reason why we try to taper cyclosporin right away. But what has been shown, you can't do it too quickly. But certainly if you are on cyclosporin for 10, 20 years, you're going to have some issues. Certainly, and it may be that other medicine has been tried and the patient has relapsed, and that's why you have to stick to cyclosporin. But if there are issues, I would certainly look at alternatives.
Thank you. Does the use of ATG cyclosporine impact the success of a future transplant?
No, not at all, no. A lot of times we use immunosuppression with ATG and cyclosporin, and then proceed with the transplant. Transplant takes a long time to get ready. I can tell you that. You have to find a donor, you have to do something called pre-testing to make sure that the heart and the lung and all the other things are in place. So it's not an immediate thing. And a lot of times patient requires immediate treatment. So a lot of times we will do immunosuppression and then work patient up for the transplant at the same time. It does not impact the outcome. The only thing that impacts the outcome is ongoing transfusions. And so if the ATG and cyclosporin allows you to avoid that, so it's actually better for the transplant in the future.
Thank you. This question comes from a patient that says, thank you for mentioning about relapse. I am 15 years out from successful ATG cyclosporine treatment. However, it appears I may be starting a relapse. Do we know what causes relapse, especially for someone in my situation so far out from successful treatment?
Well, no, most of the time in aplastic anemia, we don't know, we don't have a specific trigger, and it could be anything. It could be infection, it could be a certain medicine, it could be just, we don't know why. It's some sort of immune system issue. But you need to be sure that we're actually dealing with aplastic anemia because, like I said, patients who had aplastic anemia in the past are at a high risk for developing PNH, MDS, and even AML, acute leukemia. So you need to make sure that you're truly dealing with the aplastic anemia relapse and not some other disorder that may be associated, but not exactly aplastic anemia.
Thank you. The next question says, when would you use voriconazole versus pasconazole?
Pasconazole, yeah. Actually, there's not much difference. Both of those medications are very effective in covering for mold and aspergillus. A lot of times it depends on the insurance, whichever one insurance covers, whichever one offers you a smaller copay, they can be used interchangeably. I use either. They both are good. There's really no difference other than a lot of times it's a financial difference.
Thank you. The next question comes from a patient who was treated with ATG and has not had a complete response, but a partial response. Medical team is considering using drug therapy again. Patient does not have a suitable donor at this time.
Yep.
Is it recommended to use horse ATG again or use rabbit ATG? What is the medical preference?
Usually we do not do horse again. If there has not been a good response to horse, we do move on to rabbit. I don't know the exact age or other medical conditions that this particular patient has, but typically if there are no contraindications, I would go ahead and do the rabbit. I mean, I have a patient, very similar patient who had very limited response to horse and was not a suitable candidate for a transplant, who I gave rabbit, and he's now in remission 2-3 years. So there is nothing wrong with using rabbit. You just don't use it up front because we know that the horse is better, but there's nothing wrong with using rabbit in a second line rather than using something that already has been tried and didn't work.
Thank you. Is relapse common after a transplant?
Yeah, yes and no. I mean, it all depends on what kind of response you got with the transplant. So it all depends on, there's something we call chimerism that we measure after the transplant that shows you what percentage of you, what percentage of donor. As long as the chimerism is good, the relapse is not that common after transplant. It happens. I have seen it. It's not very common.
Thank you. This question is in regards to stress. What do we know about the stress of a patient and the correlation between autoimmune dysfunction?
There's no known association specifically between stress and aplastic anemia, as far as I'm aware, but certainly, because a lot of time we just don't know what caused aplastic anemia. Is it possible? Sure, it's possible, but there's nothing that's exact and can be measured or can be proven to cause this association. But certainly we do know that aplastic anemia is largely due to immune system dysregulation. So it is possible that stress contributes, but there is no known association.
Thank you. This question is in regards to cyclosporine. Can cyclosporine be given for life?
It is not preferable. Cyclosporine has a lot of side effects eventually that will really mess up the kidneys, and I mean there's a lot of toxicity associated with cyclosporine. We do reinstate the food dose if we tried to taper it and failed. We do reinstate it at full dose and then try to taper again at a slower rate. And like I said, there are other options for immunosuppression. You can always try tacrolimus. There is Cellcept. I mean, there are other medications that can be tried. So it depends on if you have tried everything and everything except cyclosporine has failed. I guess you have to weigh risks versus benefit in that particular situation. But no, it's not preferable to keep cyclosporine on for lifetime. I've had patients who've been on tacrolimus for a long time. That's probably a little bit better, but none of the medications are good to have for lifetime. But if you have to do something, I would try to look for alternatives to cyclosporine, for sure.
Thank you. This question is from a patient with very severe aplastic anemia and was diagnosed with optic nerve swelling. Is there an association between optic nerve swelling and aplastic anemia?
Not per se, but there can be association. So optic nerve, I mean, it could have been triggered by some autoimmune disorder that have triggered both. Optic nerve swelling can certainly be seen in certain autoimmune diseases. So there could be association that way, but not specifically between aplastic anemia and optic nerve swelling. But if the underlying cause for both was autoimmune disease or an infection, say it was an EBV virus, the EBV virus certainly can do that, can cause aplastic anemia and can cause optic nerve issues. So it depends on what was, if the etiology or underlying cause was ever found or not.
Well, thank you so much, Dr. Kogut, for sharing your time and your expertise with all of us today. We thank you for being here with us and answering all the questions as well. If you would like to watch this session again at a later time, it will be available on the conference platform in the next hour by accessing the session and clicking on replay, or you can navigate the on-demand tab in the platform. If you have any additional questions, you can send it to us at any time in 3 ways. Send an email to help@aamds.org, call our helpline at 800-747-2820, extension 2, or submit your question on our Facebook page. Please be sure to visit our exhibit hall today. Our next session will start in approximately 15 minutes. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you for joining us today, making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 38 years. This concludes our session.
Thank you very much.